Okay, everyone. Well, thank you everyone for joining. I think we will get started as we have about a good amount of people joining and attendees, and we have a very big group of our IBD group in infectious disease, about 15 of us today. So this is very exciting to see everyone. So just to start, wanted to introduce myself. My name is Anava Ren, or Dr. Ren, and I am the psychologist in the IBD Center, and I will be moderating today's town hall. So just wanted to start by welcoming everyone, and this is very exciting because it's actually the fourth town hall that we have conducted since the start of COVID and different restrictions and transitions that we've all gone through. And I like to say that we really organized this first town hall after talking to one of our family advisory council members and really realizing how beneficial it would be to have this platform where families could hear from our IBD center about what was happening and COVID-19 and its impact on IBD and our medical recommendations. And we really continued this work with our FAC to support these town halls. And even though there's been some positives, I will say, including the rollout of vaccines since our last town hall, we do know that there are many unknowns and many questions. And we do really realize this is continuing to be a challenging time and be a very helpful time to have a town hall. So the goal of today's town hall is to answer your questions and really the most pressing questions for our IBD community. So we really have two main goals today: to discuss COVID-19, the vaccine, treatment, and specifically as it applies to our IBD community. And secondly, to share key information and recommendations that are relevant to our IBD patients and families. So for those of you who submitted some questions before the town hall, we really appreciate it. We will absolutely address those today. And for those of you who do have questions, if you could submit them in the Q&A, you can see that in the bottom of your screen. We will do our best to answer them in the chat box as we go, or the Q&A box, I should say, as we go, or during the more formal Q&A session at the end of our town hall. So before we get going, I want to just introduce our IBD team. Now, I will not introduce all 16 members on our IBD team, but I do want to highlight some of our new additions to our team. As most of you know, we're growing and we are really expanding our core team. And also definitely want to introduce our colleagues in infectious disease. So to start, I'd like to, let's see, what is the best way to do this? I will say names, and if people can just wave, then I think it will spotlight you so our attendees can see which name goes with which face here. So would like to start by just introducing Kristen Wiley, who is our IBD clinic coordinator. Many of you have probably spoke to her on the phone and know how helpful she is, but I will stop talking and let her wave so everyone can see her.
Hello, nice to meet you guys.
Thanks, Kristen.
And also, for those of you that don't know, Kristen now can be a direct contact for any questions about the clinical kind of coordination kind of stuff. So if you need help scheduling an appointment or putting together different pieces of care and getting orders together and all of that, she can be a quick first person to connect to without having to go through any of the phone tree.
Yes, which is the exciting part, the lack of phone tree. And that is Dr. Benson, as probably most everyone knows Dr. Benson by now. Thank you. And Esvidi Flores Avila is our new medical assistant, and she has also started since our last town hall. So I would love to let her introduce herself.
Hi, everyone. I'm the Emmy. I'm also going to be in the phone. I'm going to be taking the phone. Maybe I'm going to be calling you. Happy to meet all of you.
Thank you, SPD. Next, we have Garrett Forshee, who is our IBD social worker, and we are thrilled to have him on. This is his first town hall as well.
Hey, everybody. Nice to meet you guys. Hopefully we'll be talking soon. Yeah, glad to be here.
Thanks, Garrett. And Steve Pond is next on my list. He's our analytics and clinical effectiveness specialist. And Steve, are you here?
Yes, I am.
Perfect.
Hey, thanks for having me. I'm really happy to be part of the team, and yeah, I'm the data person, so nothing exciting, but
Very exciting. We beg to differ. The team thinks you're very exciting. Thank you, Steve. And then Sam is also a new face. Sam is one of our administrative assistants in our division who supports us organize and put together these community events. And she's actually taking over some of the roles of Megan, who many of you were familiar with previously. So Sam, if you don't mind just saying hello and waving.
Hi, everyone. Nice to meet you all.
Thanks, Sam. Perfect. And then we have some returner faces. Many people know Dr. Goyal, Lisa, our RN, our nurse, Nicole, our research coordinator, Allison Kotzen, our nurse practitioner, and Dr. Ye. Actually, Dr. Ye, you know what, would you mind introducing yourself? Because I don't think you were on the last town hall. That would be wonderful.
Hi guys, I'm Dr. Ye, one of the Peds GI docs and also integrative medicine.
Thank you. And let's see, going down, Kaylee is another one of our nurse practitioners. Thank you. And then Dr. Bass, many people here know Dr. Bass as well, and he's been on past town halls. Perfect. So thank you all. And then in terms of our colleagues in pediatric infectious disease program, I'm really thrilled to introduce Drs. Chen and Gans and Nandimpali. And we're thrilled to have you guys here today. And they have really been leading the way in the COVID response at LPCH since the spring. And we're really excited to have them provide an overview today and an update about COVID-19, really focusing on the vaccines and the treatment. So with that, I'd love to pass it on to our colleagues in infectious disease.
Thank you. My name is Haley Gans, as was mentioned, and my colleagues Sharon Chen and Shruti Nadampali are here to answer your questions. I was just going to run through a few slides. We are going to focus on some of the new epidemiology because I think that's on everybody's mind, and then put that in context of the vaccinations, and then entertain any questions you have. I don't know if the recordings from the past town halls are available, but we did spend some time previously talking about the epidemiology as it unfolded previously, as well as treatment. And so we weren't going to focus as much on that unless questions arose. We are really trying to come at this information in the context of individuals who have IBD and to really try and understand the challenges that this pandemic has, particularly for them. So if we don't exactly answer what you're thinking about, please let us know. So Sam, were you going to start us off on the slides? Thank you. So just so you know, this is a group effort. So even though I am up here, I do want to thank my colleagues, both who work with us from the gastroenterology and IBD group, and also my colleagues in infectious diseases. Next slide, please. And we already said our welcome, and this was what we were going to cover today. So I did want to spend a few minutes on a little bit of an update on the epidemiology. We are really not going to talk about cases. That's pretty easy to follow online. If you have particular questions, please let me know. So I was going to concentrate today on the idea of viral mutations, which if we move to the next slide, we can see that just as a background, because it's very important for people to really understand this in the context. I think one of the challenges that people have really had, although it's lovely for people who are in science, is that people are really experiencing the pandemic and learning science for the first time and realizing how complex the world of science and medicine is. And I think it is a challenge to get your scientific knowledge from the media. And so I'm trying to put it into context of what we understand. Sorry, that doesn't fit right. I can't see my slides. So I was going to talk about, is it just me or viral
No,
mutation?
Dr. Gans, we're trying to, Sam's trying to fix to do a different view. So sorry about
it
that.
just got too magnified.
Yeah. Sam, if you could do presenter view, that would be great.
Anyway, I want to tell you that the important thing to know is that COVID, which is the disease that we all are confronted with in the pandemic, is caused by a virus. I think the other view was better, so if we could just stick with it, that would be great. The important piece of that to understand is that just whatever fills the screen with one slide would be great. Anyway, the disease is caused by a virus. These are in the class of viruses that are called RNA viruses, and just back one, thanks. These are called RNA viruses, and that's only important for anyone to know because RNA viruses are a special group of viruses that have to enter into the cell and then be made into DNA, and then from there into whatever proteins that they need to be viable. And the importance of that is that in that whole process of changing from an RNA to DNA, they actually do have the capacity to make mistakes. And it's the making of the mistakes that actually causes these viruses to, quote, what we call mutate or vary from one replication stage to another. And this group of viruses, which is in what we call coronaviruses, so you've probably heard that term also. I'm trying to use terms that you may have heard of and put them in context of how you may understand them. The coronaviruses of the RNA viruses are actually a little bit more stable because they do have this special reader that comes in and tries to correct those mistakes. So the one that you might actually be more familiar with is influenza. Influenza is also an RNA virus, but it actually makes lots of mistakes, and so it mutates fairly quickly, and that's why we actually have to be vaccinated against that virus every year. Well, what we know is the more and more a virus is in circulation, the more and more chance it has to actually make these mistakes and mutate. So that's very expected. The other thing to know is that when a virus is first introduced into any population or host, like a species, so humans versus bats, for instance, where it may have been for a long time, it actually is naturally going to try and adapt to its host. So in that context of the fact that viruses do make mistakes and change, and that they're trying to understand their host better, we very much expected this particular coronavirus to change over time. And it has done exactly that. It has actually mutated, but again, at a slower rate than other RNA viruses because it does have some corrective ability. And it actually is getting to know the host better. So the changes that are being prioritized are the ones that allow it to be more compatible with the host. And that's what we are seeing. So mutations make the virus actually a more fit virus. It's an advantage. And so the ones that carry the forms of the virus that carry that mutation will then soon take over and populate and be the ones that are carried from person to person. Next slide, please. So I know because there is so much news around this that I did just want to put this up there, but this isn't something that anybody needs to remember. But we are starting to see some local variation. So if you have a virus that is circulating in a certain population, it's going to have whatever changes that happen to it, and then that virus will probably be the one that's dominant or the one that spreads person to person. So they tend to be specific to geographic areas. And actually from an epidemiologic standpoint, that's very helpful to scientists because we can sort of track where things come from and understand a little bit more about that. But that's really the only reason to understand that. So we started seeing variations when the virus was actually spreading at a very high rate in the UK, as well as South Africa and Brazil. And then here in California, we have a distinction also of having a lot of circulating virus. And so all 5 of those areas actually have seen changes to this virus, and they're becoming dominant. The important thing to note about that is a couple of things. We think that these were probably present for a very long period of time, and it's really now only being discovered now that we're actually doing sequencing. So it's not necessarily that these are new. They may have actually existed, but as we allow the virus to circulate more and more, they actually can become more prevalent. And so we're seeing just more and more of them because they are more fit and more able to be transmitted from a host to a host. So that's what is known about increased transmissibility. They do have the potential to do that. Now, that hasn't actually been proven outside of animal models and outside of the fact that we're finding them more. But people haven't found actually live virus or viable form of a virus. What they have seen is that in people who have, or in hosts that have the variants, they seem to have a lot of at least the RNA around. The other piece that I really do want to mention is that there's no evidence for a change in the severity of disease. There was an early report that people might have heard about out of the UK, which showed an increase in mortality or people who are dying from the variant. But right hot off the press yesterday was a study coming out of the UK that actually showed it wasn't more severe. So again, these are going to differ depending on how you do the studies. The second study was much larger. The first study was important because it sort of alerted us to look at that. And those particular instances have not, in terms of disease severity, have not been seen elsewhere. So we're still learning, but it does not look like it causes more severe disease. Next slide, please. So we talked about increased transmissibility, and again, not something that we were surprised by. The other issue that people seem to want to talk about is there going to be resistance to protection against immunization? So if we get immunized with a coded RNA for a different form of the virus, can we be protected against this virus? Well, in the studies that have been done, the amount of antibody that actually is created when you get a vaccine is at least 2 times higher than that needed to stop viral growth from any of these different variants. So that's plenty to do what's called neutralize. It's also important to note that when people are vaccinated, they make lots of different antibodies. So they're not just one type of antibody. We call that polyclonal, if you've heard that term. And so they bind to different sites, and you have sort of an array of antibodies that can deal with multiple ways in which the virus looks. The really important point of this is we really concentrate a lot on antibodies, but viruses can't be cleared from the body by antibodies. They can stop entering a cell. And all the vaccines actually elicit very good T-cell immunity, which is the part of your immune system you need to fight viruses. And that's a really important part of this. And the other part of this to know, and just to kind of get our minds around, is that we may need a booster. So if this thing varies over time greatly, we may need a booster. But the good news is these types of vaccines that we're using now can be changed really easily. And so that will be available to us once we sort of straighten out all the issues with the vaccination and we get everyone at least vaccinated once. And the other part of that I think is really, really important, which we'll talk about in a minute with vaccines, is that the severity of disease. So when you get vaccinated, they actually all have been 100% protective against severe disease. And that's really a goal of vaccinations, even against these variants. Next slide, please. So would you like me to pause there or continue on? I don't know if people want to. I'll continue on and we'll handle.
On, Dr.
Okay.
Okay.
Continue on and then we can
Okay.
Time-wise, that's great. Thank you.
Okay. So here are the 6 vaccines that have made it beyond phase 3. So we're just going to focus on those. There's about 100 vaccines that are in some stage of being developed. And then if you just click, we'll get an animation. So the Moderna and the Pfizer are the only 2 that actually have been issued for use by the FDA in this country. So those are the only 2 that are available to us in the US. The Moderna and the Pfizer. Pfizer was first and Moderna was second. They were very large studies, and the good news is they actually showed 100% protection against severe disease, as we talked about. And they were about 95% protective against symptomatic disease, which is really well beyond what anyone thought. The Johnson & Johnson vaccine has now been issued for, they would like emergency use authorization, as the other 2 have. None of these are licensed vaccines, just emergency use. And we expect AstraZeneca to come up next. The Novavax is also coming, but we haven't heard when they're going to be ready to present their data. And the Sputnik V is one that was developed in Russia and is licensed there. It looks good, but it's not even on the docket for the US. But these are the 6 that are around, which is important to understand how the global world is dealing with these. So most of these are available in some countries and are under use. Next slide, please. So the important thing to know is vaccines do not need to completely stop COVID transmission to curb the pandemic. So we need to really actually get rid of that thought. We need about 70% herd immunity to stop transmission. And so we're at about 10% now. We have some work to do, but we will get there with the newer vaccines that will be coming into our marketplace as well. Next slide. So how many COVID vaccine doses has the US secured? The important part to know is they actually have secured many more doses than are needed in our country if we get the doses as they are secured and if the EUA status for the rest of the vaccines come into being. If you look at the tracker, unfortunately, many of the states are far below what we need. 3 or 4 states are above 10% in terms of how many people have received their vaccines. Next slide, or just hit. And if you look at this, again, this is just an accumulation of the fact that 6.4 million people have currently been vaccinated. Next slide. And then if you look at the 2 that we know are issued for EUA or emergency use in this country, they both require 2 doses 21 days apart. The first one was licensed for use down to 16 years of age. That becomes relevant to you all. And the Moderna is 18 and above. Just to give you a perspective, the US population is 281 million, with 209 of those greater than 18. We will have about 400 million doses of this. So we will be able to, and that we need 2 vaccines, so just under the greater than 18 with just these 2. Next slide. So what about individuals who have IBD? Well, there's no trials that actually include individuals with immunosuppression, so we don't have data on that moving in. But the currently authorized vaccines, both being RNA and biologically, should be safe for use in individuals with IBD. We don't worry about that biologically, so if we use the science, they haven't been tested. And there's no data has been reviewed for the other forms of the vaccine, which include a adjuvanted protein and DNA vaccines, but biologically, again, we presume they will be safe. There's just really been no studies. Responses to any of the vaccines in individuals on immunosuppression is unknown. This has, again, not been studied. And therefore, there is a chance that individuals will remain vulnerable due to a lower response. but likely they will be protected from the more severe forms of the disease. And there's really currently not going to be any restrictions on receiving the vaccines. If there are short-term increases in immunosuppression, it would be advisable to wait if that's a possibility that that short-term increase would go away. But other than that, there's not restrictions. We just don't know how people will respond. Next slide, please. So I will just put in a plug. It will be important to study these vaccine responses in children with IBD. So please let your GI team know if you're interested in studies when they become available. Next slide, please. So the vaccine allocation, we are determined by the state. So the state is who allocates out to us. We can't make up our own regimen as much as we may like to. Our current tier is just there, just so you know, we're still sort of in healthcare workers in various forms in our communities. California has a very large healthcare worker population. Next slide, please. After that, we are moving, and as you'll see from this, we have moved on to 1B Tier 1 individuals. Actually, we're at 65 and older, and we are starting to consider how to roll this out to some of these other individuals in the work sector. And then Tier 1B will be next, and you can see who that relates to. Next slide. And here's the one that's relevant in phase 1C. We will be bringing in individuals with an underlying health condition, including immunosuppression. Next slide. This is where it will be relevant to the population. That is when you will be coming. When that will happen, we are not sure. Just so you know about the age difference, Pfizer has finished enrolling 12 to 15-year-olds. So we're hoping that they are likely to apply for emergency use in spring of 2021. And so those will become available down to 12 years of age. Moderna has started enrolling 12 to 17-year-olds, but they haven't finished accruing, and we don't have a date. This is probably later this year. Next slide, please. So attending school, we feel, and recommendation is that children with IBD may attend school if the school is following proper precautions and the student can abide by masking and distancing. And there's no guidelines on mask use once the vaccine rollout is complete. We haven't gotten there yet, and we still have a very susceptible population, so there's no actually change in our masking and distancing. Next slide, please. Okay, well, that's all. I tried to answer the questions that were sent to us in advance, so hopefully I did answer some. If there's some from the chat that people can call out, that would be great.
Yeah, Dr. Gans, thank you so much. That was really wonderful and so thorough, and answered many of our questions that we received from families ahead of time. And one actually that Dr. Goyal shared was, I think on behalf of a family, was wondering about patients with a history of severe allergies, and if you could speak to that.
Yeah, so it depends what your allergy is. So that is a great conversation to have with your allergist. The RNA vaccines themselves only have a few actually components of them, and it's not thought that that would be a significant alert to somebody, for instance, that has egg allergy. So you can't just answer for allergies in general. That's something that you would need to talk to your allergist about.
Wonderful. Thank you. Wonderful. And Dr. Gans, I have a feeling that more questions are going to pop up. I know Dr. Benson, Dr. Goyal have been answering some in the chat box, but one that's coming up there's a question, Dr. Goyal, about data on IBD patients who have had COVID, and that actually is a wonderful segue to our next part. And then Dr. Gans, and if you wouldn't mind staying on, then after just a few minutes of Dr. Goyal presenting, there may be a few more. Wonderful, thank you. So Dr. Goyal is going to speak to us today about COVID and IBD data and registry, and we'll have a few minutes to talk about that, and then we'll open back up for questions.
Hello, everyone. Thank you so much for taking the time to attend this conference or town hall. So for the sake of time, I've really cut down on what we need to discuss today. So as you might have heard about this registry called Secure IBD, it is a registry worldwide where any patient who has IBD, who got COVID infection, gets registered, and the investigators who are managing this registry are able to see how have these patients done. So they look at what age were these patients at, what medications were they on, and what were their other conditions that they had, which and what was the outcome, whether they got hospitalized, whether they ended up requiring ventilators, or they couldn't make it. And as of now, we have nearly 5,000 patients, so that's a pretty sizable number who have gotten COVID infection. And as like the general population, it is relatively lesser in children, so only 30 patients are known to have registered below 9 years of age, and just short of 500 are below 20 years of age. So the good news is that all these patients have recovered. None of them had a bad outcome. And with this registry, the risk factors that the IBD patients are noted to have is if they are elderly, which is above 65 years of age, if they have multiple other conditions, for example, high blood pressure, heart disease, cancer, diabetes, if they are smokers, if they've been on steroids for a long time, especially doses above 20 milligrams a day, they are considered to be risk factors. Even though steroids are used for the treatment in severe cases, but when you get an infection while you're on steroids, that has a different meaning in terms of how this infection behaves in our body. And then several medications have been studied, and they did not find any increased risk of getting the infection or getting more severe disease with medications like Remicade, Humira, Entyvio, Stelara, or Xeljanz. And it's really interesting that our safest medications, which are in the mesalamine groups like sulfasalazine, Asacol, Lialda, for some reason, these patients did have a higher risk, but what we don't understand is the data has not been further dissected, whether these were necessarily the older patients or what about mesalamine makes them at a higher risk. So that is to be continued, as we have a lot of other things on COVID to be continued. And another signal they found was patients on immunosuppressive drugs like Imuran and methotrexate were a little bit at a higher risk compared to these other biological agents. Next slide, please. So very recently, investigators from America and Europe got together and came up with a bunch of recommendations, do's and don'ts for IBD patients. And I tried to filter them out so that there is not overcrowding of information. So obviously, just like all of us and Dr. Gans specified and emphasized on, please continue to use the general precautions, social distancing, wearing masks, hand washing. Those are not here to go in the next few months. Those patients who are receiving biologicals, please do not worry about them. There is no increase in risk of either getting the infection or if you're on a biological to having more severe disease. So please continue that. If you're on a high dose or long-term steroid, talk to your GI provider to see if at least the dose can be reduced. All patients should get their flu and up-to-date pneumococcal vaccination, so talk to your healthcare provider. Then any patient who has an IBD flare, as you might know, COVID can cause fever, it can cause diarrhea, nausea, vomiting. So it's a good idea to get checked for COVID at that time also. And if by chance COVID is negative and IBD is flaring, then it is very important to get the IBD flare treated. As much as possible, we encourage telemedicine, at least for now, until the caseload decreases. And as far as endoscopies and surgeries are concerned, if they are necessary, then they should go ahead. And just to put a plug in our hospital, any patient who's undergoing endoscopy or a surgery has to have a COVID test. And we take the utmost precautions. And I don't believe that these patients are getting infections by coming to the hospital to get these procedures. And then what are the don'ts? The highlights are, if you are on a medications, except for steroids, do not reduce the dose. By going on a lower dose of biological, you won't be more protected. Then they are not recommending switching from infliximab to Humira, just so that you don't have to come to the infusion center. And then they specified that IBD patients don't have a higher risk of getting infected or more severe disease. And then as far as your clinic visits are concerned, if you are needing to come in person to see your doctor, then adult patients are advised to come by themselves. And for children, we are highly encouraging that only one parent be there. If the other parent needs to participate, we are encouraging them to be on FaceTime. Next slide. And then I think one of the questions was, what do we do if an IBD patient has COVID? So I have come up with what is out there in the literature, but as you all know, COVID is fast evolving. So all the recommendations change. It is the flavor of the week or flavor of the month. So what's coming, what's reported in the literature may already be outdated. But what they are basic themes are, if the COVID infection was mild and the patient has difficult to treat IBD, then it is encouraged that we restart the therapy, the IBD therapy earlier in the course rather than waiting for several days. Whereas if the COVID is severe, so these are two ends of the spectrum. If the COVID is severe and your IBD is mild, then you can delay the restart of the medications. Supposing there are no symptoms in a patient and COVID is positive, as of now, the recommendation is to postpone the biological and by 10 days till there are no symptoms. 10 days if there are no symptoms, and I'll come to that a little bit later. Reduce steroids if possible. If you are on Imuran, methotrexate, mercaptopurine or tofacitinib, we recommend stopping them and restarting, I will come to in the second section. If you have symptoms and you're COVID positive, all these hold true, but restarting the therapy is either 72 hours after no fever or no medication required for fever. There is improvement in symptoms, and there have been at least 10 days passed since the first symptoms appeared. And some people want to go for testing. Those criteria are more stringent in that you have to have no symptoms plus 2 negative tests 24 hours apart. So this becomes in some specialized cases, and we should follow these guidelines only after you've talked to your doctor who will be consulting with the infectious disease experts. Thank you.
Thank you so much, Dr. Goyal. That was wonderful and very informative as well. I know answered a lot of questions and that came up about the registry today and in the past that we were emailed. So we just want to pause here and of course everyone I think probably realizes by now they are muted, all of our panelists, but if our panelists, excuse me, all of our attendees, but if anyone has questions, please feel free to put them in the Q&A. Not the chat, perfect, the Q&A as we go, and we will look out for them and answer them right now live. We have about 5 minutes for this. And otherwise, I will pass it on to Dr. Benson, who has received the various questions that have been emailed, which many of them, not most of them, have been answered already. But Dr. Benson, if any were left unanswered, I will let you answer them as we wait for any questions to be posted.
Kaylee had sent a question, what do you mean by no symptoms of COVID or no symptoms of IBD? So for stopping or for restarting the medication, Kaylee, if that was your question, it is no symptoms of COVID.
And I think, of course, as always, right, if anyone, like these are decisions that in the moment we all make together. So those are, we encourage you that if you have symptoms, you're concerned you could have COVID, or you have a COVID test, even if asymptomatic, reach out to us and we can, these are kind of our general guidelines and we can talk through with you. And as you know, we always have someone here, and either for what we feel comfortable with, we do on our own, and also part of why Dr. Gans, Dr. Chen, and the infectious disease team is so helpful is because they focus on kids who are immunocompromised and can help guide us through when to restart medications. I think I forgot to say Dr. Dunn and Polly, sorry, Struthi. But again, we have this wonderful team where we can identify what to do for you specifically. Sorry, I didn't mean to interrupt you, Alka.
So Dr. Benson, if there's any questions in the next couple minutes that we have that I don't see any questions in the Q&A that we did not get.
Some of what's on the screen or
one
something
question
that
that came across me was someone had sent a question today about the COVID vaccine. When can I get COVID vaccine for a patient? There was a question in a patient who was on Remicade and methotrexate, and when could they get COVID vaccine? So I can address that question because that's the only question that came my way. So I think those patients who are on 2 therapies with Remicade and methotrexate, we would recommend that first get your Remicade level checked at the time of the infusion, just before you receive the next dose. If the Remicade levels are quite high and in a good range, which your doctor can help you with, then it is okay to stop the methotrexate. And of course, we'll monitor them along the way. And vaccines can be available, as Dr. Gans was showing the grid line, when CDC recommends us to start vaccinating immunosuppressed patients, then of course IBD patients will be receiving their vaccines. And until then, and even after vaccination, please continue all the preventive measures.
I think one of the other questions related to that is also that I've heard from a few folks was about the timing of the vaccine. So, right, when does it matter if you get it at the same day as you get your Humira shot, or that when you're getting your infusion, or is it better to get it, halfway through or a week after? And the consensus at this point is that we don't know the answer, but that our opportunities to get vaccinated are limited. And so we should take advantage of the opportunities that come to you and go ahead and get the vaccine when we have an opportunity. And for example, we have again, since vaccine is not yet available for most of our patients, my experience comes from a few young adults who still get their care with us in pediatrics, who potentially work as healthcare workers or have other opportunities to receive vaccines. So that's kind of where my limited experience has been in terms of people actually able to go ahead and get the vaccine to date. But again, when those opportunities present themselves, we're recommending going forward and taking them as they come.
I would second that, Rachel, because we don't know if you'll respond, but we do feel like any immunity is probably helpful than no immunity. And so I would strongly suggest people take the opportunity. Rachel, did you want us to handle question 1?
Yes, can I say one other quick thing first?
Oh, sure.
The other quick thing was also a question that came kind of late this afternoon too, was about kind of you as you mentioned about like antibody response, immune response. Certainly we don't have vaccine immune response yet, but in terms of do patients with IBD mount an antibody response to the infection itself, to the disease itself? And there have been, as far as I know, 2 small case series, each with about 12 to 15 patients of children with COVID, and looking at their antibody response, and it looks like and in kids who are on biologics and on immunosuppression, and it does look like there is a detectable antibody response after infection in the overwhelming majority, comparable to the general population.
And I will just let everyone know that's a great sort of baseline foundation to go on. As Dr. Benson mentioned, it's small numbers, but it's very encouraging. And I will let you know that the current vaccines induce much higher antibody responses than natural disease. So hopefully, even if there's any diminished response, it's actually above and beyond what you need to neutralize the actual virus.
That's great. We would love it if you would respond to number 1, and then Sam could kind of also potentially go to the next slide where there are a few other questions.
So it is true that every state was provided the opportunity to figure out how to deal with their allocations. Every state did not have the opportunity to determine what is allocated to them. That was population based. And there was not actually a lot of transparency on how that was happening previously. The new administration actually is providing much more transparency, trying to move with an actual task force. And so we hope actually to get clarity on what's coming to us every week. In terms of how it was allocated, this was a really complicated formula, which involved ethicists, epidemiologists, and multiple people who were looking at 2 things. Who are the people who are constantly coming into risk, so exposure, so who is out there and being exposed at a great rate, and so would be at great risk not only for being exposed but transmitting it to other people. And part of that was also looking in populations where there was actually a lot of disease severity, so those populations who are very vulnerable. And as much as I know that it feels really challenging to wait, the good news that you heard from Dr. Goyle is that largely our children who are immunosuppressed in these ways actually haven't had a increase in the severity of disease. I mean, we feel very fortunate for that. And it's why they settled into the 1C group as opposed to somewhere higher up. Again, we hope to get down to 12 years of age, but it's also just a small proportion of individuals or children, because right now it's 16 and above. It will be 12 and above soon.
Great, thank you, Dr. Gans. And Dr. Benson, there's a couple.
Yeah, seeing some questions in the chat.
Yeah, perfect.
I think it's a great question about the kind of the symptoms and the side effects that people tend to get with the vaccine, like fever, flu-like symptoms. We generally recommend not getting your biologic dose when you have a fever, especially as we're trying to sort out, is that an infection or is it something else? So we would for sure ask that you talk with us, but we would probably suggest that you wait until those symptoms improve, and generally they're a day or 2 and shouldn't be an excessive time. And I think practically many of us, when getting our vaccines, sort of tried to be strategic around the timing as possible, so that you have a day or 2 to recover, and without anything as stressful and strenuous in case you really don't feel well and just need to take the day to rest. practically as well, if you're coming in for an infusion or have an appointment or something in person, you'll screen positive for potential COVID-like symptoms, and that will make things challenging. Yeah.
Dr. Gans, I have a question for you related to IBD patients.
Yes.
So some of our IBD patients have had anaphylactic reactions to Remicade. So
I don't think that would exclude them from this particular vaccine. Anaphylaxis to other forms of medications haven't, by our allergy people, been excluding them. But that is, again, another good thing to talk to your allergist about, to understand the actual thing for that person.
So just
to be clear, the reactions that we're seeing in vaccine recipients are actually not true anaphylaxis, they're anaphylactoid. And so it's unclear exactly what they're responding to. It might be PGE, so I don't think that's a Remicade. Anyway, that is a great question for an allergist.
So we should be referring all our patients who are eligible for vaccines but have had anaphylactic reactions to our allergists first.
Colleagues.
Thank you. Thank you so much for clarifying that.
And I just want to clarify another few things. Again, there's been no studies in immunocompromised or suppressed people who are on medications. There's been no studies, so we don't even know how long antibodies persist in the general population after either disease or the vaccine, but particularly the vaccine, which hasn't been studied as long. We're coming on 6 months. They seem to be holding their immunity. But I would just prepare that we're likely going to need a booster. So every year that you go for your flu, it might be a flu COVID shot. I just prepare for that. We're going to understand a lot more. We're going to be prepared if that were the case. And once we reach a population level where we have enough immunity, we're not going to be seeing this circulating to the point that we're all going to be relapsing back to where we are. We'll just have to go in and get another immunization.
And to keeping with that, relating to one of the questions, saying we still, even though we don't have evidence to show that the immune response is as good or is effective, we still recommend going ahead, because right now it's believed to be safe, and we think there will be a benefit even if the immune response is less than another person who's not immunosuppressed. So we think it's worth the attempt to be protected.
Again, we all need probably to change our concept of what the vaccination is going to do for us. We might get infected, we might get a little sick, but we're hopefully not going to get severe disease and end up in the hospital. So that's really the goal of this vaccine, which, by the way, is the goal for the flu vaccine as well. We don't stop infections, we just stop circulation in abroad, and we hope to protect you from severe disease. So yes, please go ahead.
And on that similar note, vaccination, it's not confirmed that it prevents you from having a mild infection that you could pass on to someone else. So you still need to use precautions even if you're vaccinated. And on that note, we wanted to make sure that we gave our last few minutes. As I want to thank one more time our infectious disease colleagues for joining us. We really appreciate your time and your guidance. And maybe we can advance the slides and move on to Garrett.
Thank you guys so much for joining. And I do see we have a few last questions, which we will try to get to at the very end. So thank you guys for submitting them. And with that, yes, we'd like to introduce Garrett Forshee again, our IBD social worker. Another question that really we've received since the start of COVID in our first town hall is, this is a stressful time, for kids, for teens, for young adults, for parents across the age spectrum, and the importance of recognizing that and really creating time to talk about it and to discuss strategies. So we've discussed this before, but want to discuss it again today. And with that, I would love to turn it over to Garrett to talk for a few minutes about stress and stress management.
Sure, thank you. And thank you everybody for all the information that you're giving us in this tough time. We just wanted to take a couple minutes to acknowledge just the difficulty of this time, of this pandemic, the disruption that it's caused our work schedules, the school schedules of our kids, the social lives of our kids and our families and our friends, the disruption in our activities that we're able to do, like stress management, stress coping skills, like sports and seeing people in the community. It all definitely takes a toll on our mental state. And so myself and Dr. Ren, our IBD psychologist, we're getting a lot of, feedback from parents and families that this is a especially difficult time for our kids. And we just had a couple tips to communicate to you guys about stress management. And our mental health definitely needs to be a priority as much as our physical health during this time. First, we definitely encourage you guys to try your best to maintain some kind of schedule and some kind of balance. And what that means is that with all these limitations in our society, we're not able to get outside and get to school, hang out with friends, do all the things that kind of gave us that balance naturally. All that structure is taken away. So we have to actually try to form that structure in the limitations of our own house. Now, what that looks like is parents is encouraging our kids to be outside more, and to get outside, get some vitamin D, get some physical exercise, even though it's not naturally going to be happening in organized sports or recess or lunchtime at school. We also, want to encourage the balance between inside and outside, being on and off screens, being alone, and or connecting with others socially. We've seen a big drop in social connection, and it's something that we really need to try to encourage, either if it's virtual, over the phone, FaceTime, or at a socially safe distance. There are a lot of resources that can help with stress management. There's applications that help us with guided meditation or breathing exercises that we definitely encourage. Headspace, Calm, there are a number of them. But also we do have some resources here on our IBD team. Myself and Dr. Ren and anybody on your medical team can help you deal with some of these stressors. So we encourage you to reach out to us and reach out to each other, because we are never more isolated than we are now, and that's taken a big toll on us. So definitely let us know how we can help you guys.
Thank you so much, Garrett, for that. I really appreciate it. Wonderful. And yes, just as Garrett said, please do follow up with medical team providers. Garrett can join any visit with your IBD provider. So that is a really wonderful thing, which we haven't had in the past to this extent. So please do let providers know ahead of time or during the meeting if you would like to talk to Garrett about stress or anything else along that matter related to COVID. And myself, you can schedule appointments with me too. So wonderful. So thank you. I'm looking at our time right now, and we did want to have a little bit of time to discuss our Improve Care Now network and some research, but I want to make sure, let's see, Dr. Benson, any last questions that you wanted to address before we move into that?
Nope. I'm answering one question, but I'm really slow at typing.
Okay, everyone wait for Dr. Coyle to finish typing.
Feel free to type, and Sam, you can advance the slides.
Yeah, I'm answering that question about the proof of diagnosis.
Wonderful. So we'll multitask, and Dr. Benson will take it away now with Improve Care Now and giving a little bit of information to our community here.
We just wanted to take the opportunity for those of you that are not aware of our Improve Care Now or how you can join. It's another way to connect with our IBD network and other families with IBD. So if you are not familiar, please check out their website. There's a website. That QR code will also link to it to join the circle, which is you can get some email updates and information. They have toolkits for families. They have a parent advisory group and a patient advisory group where you can connect with others and kind of help inform our care and improvement projects for others. You can go on to the next one. Sam, there we go. Oh no, go back one. Can you go back one? Again, that's the QR code. This is our Patient Advisory Council. We are thrilled that now we have 2 of our young people who are involved in this national network. No, you were on the right one. Sorry. Anyhow, including sharing posts and again, helping participate in these this information. So we are, again, encouraging more of you to connect, and we're really proud to be connecting nationally with others and other centers. Now go on to the next one. We also, Improved Care Now and has involved in research where we can share our data with other centers. If you have not talked to us about this, we would love to. We also have some other research studies going on, and Nicole, say hello again.
Hello.
Yeah, Nicole is our research coordinator. There's her contact information. If you're interested in participating in research, reach out to her. We are thrilled anytime that any of you are interested in learning more about what we're working on or participating in some of our projects. Things that we have going right now, some relate to diet therapy and IBD, related to kind of coping and living with IBD, related understanding kind of environmental triggers. We have quite a number of different studies, so keep your ears out. And if you're particularly interested, and we love to hear from you.
Even if you're a little interested, we will be happy to hear.
That's true. And you can also always send a message to your IBD provider, and we can have Nicole reach out to you. So
and I just wanted to put a plug in for the environmental exposure. So it's a pretty cool study because these have not really been studied in detail, and our scientists have developed these special boxes which measure your environmental exposure. It takes into account what you're eating and how your body is doing in terms of IBD, and tries to correlate all these, which is a very unique study. So Nicole is your girl, and we are all here to give you information for that.
Thanks, Dr. Goyal, for that. It is
our IBD Center is growing, and we're going to be having more research and hopefully, again, more activities. So many of you know about this because you're on our email listserv, but if you are not, there's the email address so that we can reach out to you. And as Inbal put in there, think about joining the Improved Care Now Parent Working Group, or if you're interested in participating in our Family Advisory Council here at LPCH, again, let your provider know or let Garrett know. And let us know if there's other types of events that you want to hear from us. This all started because of feedback from families. So we want to hear if there's things that we can do to help. And yeah, thanks for joining.
Just saw one comment. Thank you so much to our attendees and our patients who are involved in the Improved Care Now Patient Advisory Council. We're thrilled. So thank you guys for all of your work. Yeah. And on that note, just to be aware of time, I know we're a few minutes over. We could probably go for another hour, but I promise we will let you go to your dinners and your families, but just really want to thank you all for taking the time and joining us today for this town hall. And we plan to continue this. And so please give feedback to providers, or if you're on one of our various councils, let us know when another town hall would be helpful. So any other questions that we didn't get to? It looks like from what I can see, we've answered all of the open questions. Thank you, Dr. Goyal and Dr. Benson, for doing that live. And do follow up with us, though. Any of your main providers, let them know your questions. We're here for you. And again, we do know this is a challenging time. We know there are new questions, every day, and news comes out, leads to new questions. So at any point, might chart us, however you get in contact with your provider, and we're here to support you. So thank you guys all for joining again, and I hope everyone has a wonderful evening.